Hello, my name is Emili Montserrat. I am from the University of Barcelona in Spain, and it is my pleasure to share with you some key slides of my presentation on CLL then and now. Small lymphocytic lymphoma and CLL are actually the two ends of the same spectrum, the same kind of neoplasia, the only difference being that if the disease predominates in peripheral blood, we call it leukemia, CLL. In the case the disease is present in lymph nodes, we call it SLL. There are a number of immunophenotypic and genetic studies indicating that there are no biological differences between what we call SLL and CLL. In terms of diagnosis, the diagnosis is made on an arbitrary basis. We take more and less than 5,000 monoclonal B lymphocytes in blood. If the patient presents with more than 5,000 lymphocytes, then the diagnosis is CLL. In the case the lymphocyte count is under 5,000, there are two possibilities. Number one, either the patient presents with lymphadenopathy, spleen, liver enlargement, anemia, thrombocytopenia. If any of those is present, then the diagnosis is SLL, small lymphocytic lymphoma. If not, we call it monoclonal B-cell lymphocytosis. And within monoclonal B-cell lymphocytosis, there are two subgroups. One, which we call low-count MBL, defined by less than 500 monoclonal B lymphocytes per microliter in blood. The other one, high-count MBL, more than 500 lymphocytes per microliter in blood. Actually, as I said, this classification is quite arbitrary. Biology doesn't speak threshold, and there are no plausible reasons to differentiate what is high-count MBL from CLL. The diagnosis of CLL relies on a careful examination of peripheral blood smears, showing the characteristic morphology of CLL lymphocytes and also the immunophenotype, the technique of capillary exclusion to demonstrate that the proliferation is monoclonal, low expression of immunoglobulins on the surface of the cell, CD5 positivity, CD19 positivity, weak expression of CD20 and CD23 positivity. A new marker, which is CD200, which is quite specific of CLL, improves the diagnostic accuracy of the immunophenotype and decreases the number of cases in which the diagnosis is not clear-cut. It is important to keep in mind that in CLL there are two main forms of the disease based on the mutational status of the IGHV genes. In the case in which those genes are unmutated, there is cell activation, an increase in genomic instability, appearance of deletion 17p, mutations of p53 and others such as NOTCH1, SF3B, etc. In the case that the IGHV genes are mutated, then the cells do not suffer genomic instability. The cells only accumulate slowly and there are no poor genetic features. Actually, deletion 13q, which is a good prognostic marker, predominates in mutated CLL. A mutated CLL has very poor prognosis, whereas that mutated CLL has an excellent outcome. In terms of prognostication, as in any other kinds of cancer, we are moving from prognostic factors to predictive factors. Prognostic factors are those that predict the natural history of the disease upon no therapy or no effective therapy, whereas predictive factors are those which are mainly biological factors that predict the response to a given therapy. Here, it is very important to emphasize that with chemoimmunotherapy, response to therapy, particularly if there is no detectable minimal residual disease, is the most important predictor of survival. This table shows the most important prognostic and predictive factors. In terms of prognostic factors, the important parameters are clinical stages, IGHV mutational status, and FISH cytogenetics. A complementary value is for beta-2 microglobulin, the absolute lymphocyte count, dueling time, and the expression of ZAP70, CD49D, or CD38. In terms of prediction, the important markers are deletion 17p p53 mutations. Actually, this is the only predictive factors that we use in clinical practice. Also, deletion 11q. And complex karyotype mutations of NOTCH1 and other newly described mutations require further studies before being incorporated to the prognostication of patients with CLL. Actually, prognostic and predictive factors overlap, so prognostication in CLL can be seen as a kind of dynamic process in which at the diagnosis you can get an overall prognostic information provided by clinical stages. Then IGHV mutations are extremely useful to predict the likelihood of disease progression and hence therapy. And as I said, response to therapy is dictated with chemoimmunotherapy by deletion 17p mutations of the p53 gene. I'm going to finish by showing you a number of important progresses made in the treatment of CLL, progresses which have been really important. From 1970, when the only agents that we had to treat CLL were alkylators, chlorambucil, cyclophosphamide. So with a very low proportion of complete responses, the goal of therapy was palliation. And then we moved, thanks to purine analogs in combination with alkylators, and more recently with chemoimmunotherapy, which is the gold standard for patients that can tolerate it, to a high proportion of complete responses, many of them with no detectable minimal residual disease. And now there is a challenge of the new molecules, particularly B-cell receptor inhibitors, BCL2 antagonists, CAR T-cells, etc., that are extremely useful even in forms with deletions of 17p and p53 mutations, and at the same time challenge the notion that whether or not achieving a complete response with no detectable minimal residual disease is mandatory to prolong survival, or survival can be just the result of a better control of the disease with no necessity of achieving CR. That's all. Thank you.